Welcome to Access Amplified, the podcast where we shine a light on how digital health is increasing access to care and advancing equity around the world. I'm your host, Joanna Brownold, and our podcast is brought to you by Taito Care. In each episode, we sit down with healthcare leaders who are doing the work, not just reimagining access, but rebuilding it from the ground up. Today, I'm joined by Abby Losinski, Director of Telehealth at St. Luke's Health System in Idaho. Abby, thank you so much for joining us today.
Yes, thank you for having me. I'm excited to be here.
We're excited to have you. Abby is fantastic. She has over 18 years experience in healthcare, and she brings a rare mix of clinical, technical, and operational expertise. And she's working to bring care closer to home in the community of Idaho. We'll talk about what it takes to design truly consumer-first care, how to partner with communities in meaningful ways, and why sometimes the key to innovation is thinking more like a startup than a health system. So, Abby, let's start with some background. Can you tell us a bit about St. Luke's Health System and your role within it? You're working across Idaho. What kind of access challenges does your community face?
St. Luke's Health System is based in Southeast Idaho. We also have some service locations in Eastern Oregon. And Idaho is a rural state. So all of our counties, except for two, are considered healthcare provider shortage areas. That's the designated category that most of our areas fall into. So access is a challenge to say the very least. And I know that most states struggle with this. I feel like we struggle a little bit more because we are so rural. I am the director of telehealth. That's my title, but I really do a lot of things in the access space, really looking across the system for opportunities on how we can make that access easy, which, as you know, in healthcare is no small feat.
Absolutely. So let's dig in to how you're supporting your community and how you're approaching these challenges with digital health. How does your on-demand virtual care service work? And, as you mentioned, you're so rural. Who is it designed to support?
Yeah. So on-demand virtual care started in 2021 in response to COVID. We turned it on for 7 symptoms. We really only wanted to use it for our established patients. And 2 months later, we realized we have this centralized team of providers. We should probably be using it for more than just 7 symptoms and for our existing patients. So we immediately scaled to really allowing patients to join for whatever they want to talk to a provider about, whether they're established with us or not. So we might just be meeting a need in the moment when somebody's in Idaho or new to the area, or they're established with another health system, but access isn't available. We're taking care of whatever the patient needs, and we make that workflow as easy as possible to be able to be something that patients think of first when they're looking to talk about whatever their health need is. The last thing we want them to do is to think their only option is to go to the emergency department. We want them to know that this is an option for everyone, and to be able to have that real time access to providers is extremely valuable in a rural state.
Absolutely. And is that, so you're talking urgent care and primary care, or just really across the spectrum of everything?
Really, across the spectrum of everything, we don't put any barriers around who can join or what the need is that they're joining for. So we ask them what brings you here today, and they fill in a free text box, but there's nothing that stops them. So we've had people in active labor, we've had people in with cardiac events, and then the easy sore throats and UTIs as well. A large majority of our population is also just people looking to establish care with primary care. So it's a broad range. We've partnered with specialties to be able to offer some of those services as well. So we just our goal is get them straight to provider and let the provider figure out where do I need to do a warm handoff or what can I treat. And 96% of the time they can treat that immediate need. Because we make that access so easy and we train our providers to really handle as much as they can virtual.
And is the 4% the active labor?
Yes, yes, and the cardiac events, appendicitis, things that we truly can't evaluate virtually. But it usually for things that need in the moment care, like I said, 96% of the time we can take care of those things at least temporarily until they can get in person.
Okay. Just imagine like a bank of doctors and one guy answers the phone and he's got a UTI and the other guy answers the phone, he's got somebody going into labor and
Yeah.
he's like, "Why didn't I answer that call? That would have been."
Right. Yes, and if my providers were here, that is exactly what they just would describe. You just don't know what's gonna come through the virtual door, and we staff to support the 5-minute visits or the 45 minutes, and it's not dedicated time, it's a queue. So you never know what it's gonna be, but we make sure that our providers know they can spend that needed time with a patient that's in mental health crisis, or a patient that just needs someone to talk to about a variety of things. They need to be able to spend that time and not be rushed. And in healthcare, we're so rushed, and patients feel that, and that experience, they remember it, and they don't really want to come back when they felt rushed. So we want them to use the service. We want them to know it's an option, and it's like phoning a friend. I can text a physician anytime. I know enough of them. Most people don't have that luxury, and so this is as close as most people are gonna get, and we wanna make it as easy as it is me texting a.
Absolutely. And one of the programs that we've spoken about is some bridge programs that you run. So can you explain how they work, how they're helping people who would otherwise fall through the cracks?
Yeah. So because of the healthcare provider shortage, it takes about 9 to 12 months, if you're lucky, 3 to 6, depending on the area, to get in with a new provider. So when patients are out of prescriptions, they need a referral. That's a really long time to wait. And so we offer a virtual opportunity to start that process to establish care. So we refill meds, we place the referrals, and we really manage their care until they can get in with that new provider. And that can include ordering mammograms, ordering labs, things like that, so that they're not delaying their care. And what we've seen if we don't offer this ease of access for new patients is they just never get established. And those are the folks that are using our emergency departments for low acuity needs because they don't have a primary care physician to reach out to. So the more that we can get patients plugged into the system, even if it's not St. Luke's, if it's, one of the areas in our network, then we're still establishing them and that helps their care long term. So that's our biggest bridge program is for primary care new patients. We also have opportunities with urology or oncology when they're not able to get patients in for some of those low acuity needs. They do just send those patients our way. Patients who have a primary care provider and the primary care provider is unavailable, they're out of the office, it's after hours. Those departments send patients our way. And so we've really built an integrated process of whatever number you call, wherever you look on our website, virtual care is available. And so what we found is, across the US, we say virtual care is really scaling back. It's not really that virtual care isn't of interest to our patients. It's that we're not offering it enough. So when
Mhm.
you offer it, they'll choose it because they'd rather do that than wait. You just have to offer it. And so we are really integrating it in every workflow that we have. We have some virtual first approaches. When a patient calls our central scheduling line for one of 5 symptoms, they are offered virtual first before a PCP visit. And that allows our primary care providers to have more time on their schedule to establish those patients that would have normally had to wait or to see patients that need in person evaluation. So
Okay.
that's our biggest bridge program. And we ask every single patient that joins for a visit, do you have a primary care provider? And if they say no, then we ask them, do you want to establish care today? So even if that wasn't what they joined for, we offer that opportunity and make that easy right there. So we're really being proactive about getting patients established with primary care because we know that it leads to better health.
Right. So I was gonna, if I join one of your programs or if I call and I say I don't have a virtual care provider, but I need help right now, um, is that then also gonna funnel me into that potentially funnel me if I want into that bridge program whereby so you're kind of covering the whole spectrum there. They've got care today, they're adding themselves to a list to make sure they'll have care
Right.
tomorrow and 6 months down the line as
Yeah,
well.
we go through the whole new patient visit, so it takes us a little more time, but, updating their chart, refilling their meds, and then putting that scheduling request in that has someone call them to schedule that first visit with the primary care provider. So we try to take the burden off of the patient and put it on ourselves a little bit so that the patient's not having to take an action. We're doing that for them, and all they have to do is say yes. So we've seen just from asking that one question, would you like to establish care today? Just double the amount of new patient visits. So it shows if you offer, people will often say yes, but you have to ask the question.
Right. You have to give them the chance.
Yeah.
And you mentioned the impact on the ED usage, and I assume it's kind of having an impact across the health system. Can you tell me about how that's impacted?
Yeah, we know that 90% of our patients would have gone to the urgent care of the emergency department if they didn't come see us.
Okay.
So we know we're reducing unnecessary ED visits. It's anecdotal. You don't know for sure where they would have gone, but we can gather that that's where they would have gone. But we also have processes where when those patients do arrive to the emergency department and they do see an emergency department provider, the provider has a partnership with us. So when they recognize this patient had a low acuity need and they don't have a primary care provider, I'm going to send this appointment request over to the on demand team and we reach out to them and we get them scheduled to establish care. So we're again being proactive and the providers can decide this is a really good candidate to prevent from coming next time. So you kind of see that change in behavior over time. We started that process about a year ago and we're already seeing some change, but it takes time. I always say it takes years for a river to change course. And so, for our population to learn, emergency department is not your first choice. We're continuing to do some marketing around that. Call us first, use virtual first. And then, really, I always say internally it is our best marketing. So, the more that trusted providers offer virtual and remind patients to use that next time, the more that patients will.
Right. That makes a lot of sense. Like if I hear something from my doctor, I'm more likely to listen to that perhaps than, from an email or something.
Right.
And something else that I wanted to touch on is the other ways that you're reaching the community. So you've placed telehealth hubs in some really interesting community sites. Can you tell us a little bit about that, what that looks like, and what kind of impact that's having?
Yeah, a huge component of human-centered design is to really think about all of those personas. What patients are out there and what ones are not choosing virtual from home and why aren't they choosing that? And so thinking about those patients, we decided, not everyone's going to feel comfortable starting a virtual visit from home for the first time. Maybe they don't have internet access. I know that sounds crazy, but that does happen in Idaho. There are
I was gonna
people
say you're in
without internet
rural.
access.
Right, exactly. You're in
Yeah.
rural Idaho. There's gonna
Yeah.
be internet
Or
challenges.
they don't have a camera, right? They don't have all of the technology that's needed to make this successful, and we have really low requirements, really low bandwidth requirements, but you still need something. And so what we've done is we've placed technology in trusted community spaces. So most of those rural communities do have a library, and the library does have internet access. So we're placing the technology in those libraries, in schools, YMCA's. And we're also partnering with the fire department and the ambulance organizations around us that when a 911 call does come through and it is a low acuity need, that they offer telehealth before transporting them to the emergency department. So, really getting ahead of that process where the patient would show up for a low acuity need, let's offer telehealth on the front end. And then hopefully the patient will not call 911 next time. So, a big part of the message is offer telehealth and next time just call this number or just use this QR code and you don't have to call 911 for these types of needs. Of course, if it's an emergency, they should. But for, they have a cold or, something like that, they really should be using virtual first. So that partnership is really boots on the ground. The librarians, we consider them boots on the ground. They are a huge resource to our communities and they really care about being there for our patients. And so the big thing we have to do is show patients that libraries and YMCA, those are places you can access care. It's not front of
It's not.
mind to think I can go to the library and see a provider so what we've done is really have a program that doesn't just place technology and leave, but actually is a ongoing partnership. So we have a nurse practitioner that travels to each of those locations, different location each month and offers free health screenings and training on how to use telehealth. And so he's just available for walk-ins or people can make appointments ahead of time and he can do those screenings and tell people, okay, next time you can use this equipment when you need to talk to a provider. And it also trains the staff there, gets them really comfortable with us, gets them comfortable with the technology and speaking to it. So we really try to make that just an ongoing offering, and it also builds trust in the community that we're here and we're putting things in a place that makes sense to you, not just what makes sense to us and is convenient for us as a health system.
Yeah. So, I mean, I assume you kind of mentioned that there will be a nurse who will be physically present. And in terms of leveraging those non-clinical librarians,
Mhm.
you said that you're training them. I assume that there's also an element of that marketing that goes on in the library as well, right? Like I go to the library one day for a book. I'm assuming there's some kind of signage or something so that they know that they can come back there.
Yeah, so they have a telehealth pod in most of these libraries or a telehealth room, and that space can be reserved by patients for any need. So it could be to see someone for another health system, it could be to have an appointment with a lawyer, it could be to have an interview. So they can use it for multiple things. So the library really advertises that as a schedulable room to see a provider, to have any kind of video conference. And so they have signs, take your telehealth appointment here. They of course have our flyers, but we are just a choice. They're not required to use St. Luke's. We're a choice. So we just make it really clear these are your choices. And we're still continuing to raise awareness around that. And really it's word of mouth. One patient uses it and tells their neighbors about it, and then they're going to use it. And so we're just kind of continuing to build that.
Yeah. So, I mean, what has the community response been like? Are people enjoying this?
Yeah, I mean, we don't have as high a volume as we like, and that's part of, just building that process up. But we continue to put articles out in the news. We've done a few segments, and really just let people know we're available and build up the confidence of the staff on the ground to make that available and front of mind for them and their patrons. And then as far as the fire department and ambulances, we're expanding our criteria. So we started with a pilot of 2 trucks, and we're now moving to 21. So we're realizing this works. We've avoided some ED visits, so let's expand and be able to offer this to more patients and have it on all of our trucks. So that's been really successful, and I would say they are the most excited about this program because they know they're transporting patients that don't need to go, and that costs them money, them time, and the patient money. And then, of course, the system as well for low acuity needs in the emergency department that costs us as well. So,
Mhm.
yeah.
Just to talk about that fire program for a minute. So the call out still happens, I assume. The ENT,
Yeah, EMTs are paramedics.
yeah, they will still go to the home of the person who's called out, and then they'll be basically treated remotely from there, as opposed to them being transferred. Is that how it works?
Correct. Yeah. So, and that frees up an ambulance. So every time that someone has to be transported, an ambulance has to come on site and they have to load them up. And that takes that ambulance away from someone else that could need it. So they're able to come to the call just in one of their other apparatuses and then not need to call that ambulance. Or if it's the ambulance company, then it just frees them up a lot quicker than it would be if they were had to
Right.
transport.
And I assume especially in rural Idaho, that's could be a time-consuming
Yeah,
drive as well,
exactly. Yes.
right? Okay, that is so fascinating, and I love the kind of imaginative approach and creative approach that goes into this. I mean, so a lot of the program elements that we've discussed and the way that you're approaching this really has those patients at heart. And I know that you're passionate about consumer-led design. Um, and often consumer-led and healthcare don't always go hand in hand. So how are you kind of taking that approach when it comes to St. Luke's and when it comes to healthcare?
Yeah, well, we take our survey responses very seriously. So we of course use Press Ganey and we use Google reviews. I review those every single month, and we evaluate. Okay, is this new button that we've placed, is that working? Is this workflow causing more of a burden or less? For example, I mean when we went live with Title Home, so some of our we have our health plan members and our employees that have option to enroll in the Title Home program. So they get this wonderful device that we can see in their ear, listen to their heart and lungs, and expands what can be treated virtually. And initially, we just had a visit type that they clicked, and it was a Tito visit type. And you would think, okay, straightforward. I'm going to schedule my visit. I'm going to click Tito as my visit type, and we give them instructions. but they weren't clicking the button, even though it was right there and they got instructions. So we decided to automatically switch the visit type for them. So if they have paired their device, then it will automatically schedule a Tida home visit, so they can pick general illness or they can pick new patient, but it will be a Tido platform visit. And so they don't have to think about it. They're just clicking, what am I here for today? I'm here for illness. I'm here to establish care. I'm here because I'm pregnant, whatever it may be. And I just need to choose that. And then we take care of the technology on the back end. So that's a really good example of, the recommendation was just put a visit type in there. That's what Epic tells us to do. And then that visit type drives the platform. But it wasn't as easy as we thought. And if we didn't look at the feedback and watch the behavior and be willing to change, then we would never get there. And what I tell my team, and it's not their favorite statement, but we will always be changing things.
Hmm.
And when I hire them to the team, that's what I tell them. And the reason why is we're doing this for the patient. We're making the service relevant long term. And if we think we can just implement something once and that's what it is forever because nobody likes change, then nobody will use it. And so, we have to continuously be changing. And when you think about the companies like Amazon that do this really well, that's what they're willing to do. They're willing to try things and maybe it fails and maybe you have to turn it off. And that's really scary in healthcare. But that is the key to success is
Yeah.
being willing to try and being willing to abort when it doesn't work and be willing to scale when it does.
Hmm.
And so it can be hard on the team to have to absorb that change, but we always try to space them out and, the best communication that we can. And it's always coming back to what are our shared values? Every time we change something, we are changing it for the patient. We are changing it for the experience. We are changing it because we need to be the easiest access so that people will use us first. And when everybody has those agreed upon shared values, it's a little bit easier to get over that fear of change and that hurdle of, that change fatigue. So, yeah.
Yeah, no, I think, and it's almost like a kind of a startup approach within a health system, which is typically a little bit slower moving than a startup.
Yeah.
Um, and you mentioned how it works with your team, but I can imagine that also within the wider health system, there may have been some challenges with this approach. Have you faced, resistance or skepticism, and how do you deal with that?
Yeah, so I fall under a department called Consumer Access and Experience. And so we were stood up specifically to try new things. And that was about 4 years ago now. And initially, again, change is scary. And when the reason why it's scary is what will it take from me? What will this change take from me? And so it took years, about 2 years to really show the organization we're not here to take something from you. We're here to give something to you. So when you give us the patient from primary care because you don't have time on your schedule, we're helping you keep that patient because we have good access for you. Uh, when we see new patients, we're getting that patient for you so that they establish with you long term. And when we choose virtual first, we're not taking something from you. We're actually opening up your schedule so you can build your panel. And so it just takes time for people to see that you actually are here to help them build what they're building, not to build your thing on this side to compete with theirs. And my boss, Mary Cronin, she always uses the example of Toyota. We didn't create the Prius to kill the Camry, right? It was just we had to create something that really targeted that group of consumers. And we're not good at that in healthcare, right? Everything seems like we're building these different silos and building them up and it's great work. Everybody does great work. Everybody has a great heart, but we've got to work together to take care of the patient together. And so it's just time and it's proving trust and it's showing that the success of when you try something that you were scared to try, look what happens. I think the biggest difference with consumer access and experience is that we're willing to try with before we have all the answers. And it makes sense the rest of the system can't do that because we have to meet the standards of the rest of the organization, right? This is our standard workflow. And if we go away from that, then every clinic's doing something different. And we can't do that. But we have the ability to just do it, see what happens, and then bring those learnings back to the system so that they can decide if they want to build that into their standard. So it's really hard to do that if you're not a little bit separated structure wise to be able to try those things. But then when you're separated, it also feels like a little bit of a threat. But when you build up that trust, and we are there, I'm so thankful for my primary care partners and specialty partners. They do see us as part of their team, and that's been my heart and my goal to show them that, and we're at that place where they do see that. So for those trying to do this and maybe encountering those same issues, just give it time and consistency, and you will get there.
I think that's really heartwarming as well because obviously it's a journey and obviously it's something that's going to take time. Um, and to see that, you guys have been able to persevere and make that impact over time and kind of educate or market or however you want to term it internally. Um, that's a big part of the process and getting everyone on board. So I want to wrap up now with one final question. You've been at St. Luke's for over 5 years, and obviously you're constantly working on new projects and new ideas and new angles. What keeps you inspired and what are you most proud of in the work that you're doing right now?
Yeah, it's throughout my career, it's always been about making an impact, whether that's direct patient care or building the EHR for providers and patients or being in operations like I am today. What's kind of my guiding light is, am I making an impact in healthcare and am I making a better impact than how I came into it? And so I guess what makes me the most proud is just the opportunity that I've had to build a team from the ground up and to build a service line from the ground up. Most people do not get that opportunity. And so I got to be a part of molding this culture together with the team and really deciding how much burden are we gonna put on the patient versus the system? And we're willing to take that burden on, and hopefully show the system that when you do that, these are the good things that happen. So being able to have that impact and really be able to truly say we put the patient at the center of everything that we do, that's the most rewarding. And making something easy for a patient that has been difficult in the past, that matters to me, and it's what keeps me coming back every week to continue doing that.
I think that's really, really special. And the impact that you're able to have on the health system and also on individuals is huge. Thank you so much for joining me, Abby. This has been a really great conversation.
Yeah, thank you for having me. It was great to talk to you and share everything we've done here at St. Luke's.
I really think that, your approach to, I guess, like rapid innovation is a refreshing way to think about healthcare. So thank you. If you enjoyed today's conversation, please be sure to follow or subscribe wherever you get your podcasts. New episodes are going to drop every 2 weeks, and please share this episode with a colleague who is passionate about digital health access or rethinking care delivery. Access Amplified is brought to you by Taito Care. I'm Joanna Brownell. Thank you so much for listening, and we'll see you next time.